I'm Greg Schwartz. I'm a cardiologist at the University of Colorado School of Medicine in Denver. And I'm pleased to tell you a little bit about the ODYSSEY outcomes trial, the results of which were just presented at the American College of Cardiology meetings. ODYSSEY outcomes was a trial in 19,000 patients, roughly 19,000 patients, with acute coronary syndrome within the past year and levels of LDL cholesterol that remained above 70 milligrams per deciliter despite being on intensive or maximum tolerated statin therapy. Why did we do this trial? Well, we know our patients with acute coronary syndrome are at high risk for further ischemic cardiovascular events. We know that one of the determinants of that risk is the level of LDL cholesterol. We know that reducing that level with statins is effective in reducing events. And we learned from the IMPROVE-IT trial that adding ezetimibe, a relatively weak cholesterol-lowering agent on top of statin, nonetheless reduced cardiovascular events. PCSK9 is a validated target for therapy to further reduce the levels of LDL cholesterol, and we learned in a previous trial called FOURIER that in patients with stable cardiovascular disease, risk of cardiovascular events can be reduced with a monoclonal antibody to PCSK9. In this trial, we tested whether such an approach could further reduce the risk in patients with acute coronary syndrome. So we enrolled patients with a level of LDL cholesterol at least 70 milligrams per deciliter despite treatment with the two highest doses of either atorvastatin or rosuvastatin, which were used in about 89% of the patients in the trial. In fact, the median LDL cholesterol level of patients at entry was about 87 milligrams per deciliter. As expected, treatment with alirocumab, a monoclonal antibody to PCSK9, reduced the levels of LDL cholesterol substantially compared to a placebo group, again, both on a background of best statin therapy. And what we observed was that there was a significant 15% reduction in the risk of the primary cardiovascular outcome of the trial, which was a composite of coronary heart disease death, non-fatal myocardial infarction, ischemic stroke, and unstable angina requiring hospitalization with a very stringent definition of that latter endpoint. We also observed a 15% reduction in all-cause death in patients treated with alirocumab compared with placebo, and this corresponded to approximately a 0.8% reduction in death. Now that result has to be qualified because we tested a number of secondary endpoints in a pre-specified sequence, and there were two endpoints, coronary heart disease death alone and cardiovascular death alone, which were tested before total death and didn't reach significance. So therefore, the significant finding, a 15% reduction in all-cause mortality with a p-value of 0.026, we are considering a nominal p-value because of this hierarchical sequence of analysis. Nonetheless, we took that observation and looked in particular at subgroups that appeared to derive the greatest benefit from the treatment. And the subgroup that appeared to derive greatest benefit was the group of patients, about 5,600 patients in this nearly 19,000 patient trial, who had an initial LDL cholesterol level above 100 milligrams per deciliter. And in those patients, comparing treatment with the PCSK9 antibody alirocumab with placebo, there was a 24% reduction in the composite primary endpoint and a 29% reduction in all-cause mortality. And both of those findings corresponded to significant, clinically significant absolute risk reductions in those measures of about 3.4% for the primary composite endpoint and 1.7% absolute reduction in death, again, in the subgroup of this trial with LDL cholesterol levels above 100 despite best statin treatment. So we established benefit, but importantly, we also examined the safety of this approach. And we saw no excess of any adverse event in the patients treated with alirocumab compared with placebo, except injection site reactions, which were almost always minor and consisted of redness, swelling, itching, and the like. There was no increased incidence of neurocognitive adverse events, diabetic complications or new onset of diabetes, no increase in hemorrhagic stroke or any other category of adverse event with alirocumab versus placebo. And importantly, in this trial, there were over 8,000 patients who were enrolled with a potential duration of follow-up of at least 3 years. So we have additional confidence based on that in terms of the safety, at least in the time frame of this trial. Patients were followed as long as 5 years and a minimum of 2 years. So our conclusions are that alirocumab added on to best statin treatment reduces a composite cardiovascular outcome consisting of coronary heart disease, non-fatal myocardial infarction, ischemic stroke, and unstable angina. There is an associated reduction in all-cause mortality, and there are no safety concerns that are raised with this treatment. So we hope that these results will help to expand the numbers of patients who are able to be treated with these agents, help to further reduce cardiovascular events in our highest risk patients, and hopefully make a contribution to the care of these patients in the future. Thank you.